RetinaRounds, episode number 185, Giant Retinal Tear Pearls. In this episode, co-moderator Dr. Ehsan Rahimy and I review a surgical video submitted by Dr. Bruno Felipe Silva, a vitreoretinal fellow at the University of São Paulo in Brazil, under the supervision of his attending Dr. Marcelo Rego. Using this case as a framework, we talk through practical steps to optimize success when repairing a giant retinal tear detachment, from preoperative planning and intraoperative setup to key maneuvers for stabilizing the retina and minimizing complications in the OR. Thank you, Dr. Felipe Silva, for sharing this case. All right, Ehsan, welcome back to Retina Rounds. Today we're going to talk about a case that was submitted by Dr. Bruno Felipe Silva from Brazil. And he has a case of a patient with a giant retinal tear. This is a macula involving detachment in the supratemporal quadrant of the left eye. So let me show you the preoperative photo. You can see that supratemporal detachment. The retina is sort of folded over itself. It looks like it extends from about 11 o'clock to roughly 3:30 or so. I don't know the lens status for this patient, but in this type of a case, what do you want to know, and what are you thinking in terms of your surgical plan?
Yeah, these can be tricky cases, and as we know, these kind of cases they go like 0 to 100 really quick. So when I'm seeing one of these, I'm really trying to expedite getting them into the OR. There's clearly some degree of very abnormal vitreoretinal interface pathology here that's causing this retina to unzip. And I've seen some of these that looks like this. When you're seeing the clinic, by the time you get to the OR, this amount of detachment and the extent of the GRT is just multiple clock hours more. So these are ones you're really just trying to get them in there as quickly as possible. You mentioned the lens status. I think that makes a big deal in cases like these. You really want to get, assuming part of this proposed correction is going to be vitrectomy, you want to get really good scleral depression, anterior shaving your vitreous space, cleaning up the horns. And so again, your lens status is going to potentially influence that. So it's relevant to know whether they're phakic or superphakic. Surgeon's choice in terms of how they want to repair this. This is something that gets frequently debated at meetings. We see this as part of the ASRS survey. Is this something you're going to do vitrectomy alone, or are you going to do a buccal and a vitrectomy? We've seen various series over the years from colleagues both here and internationally that suggest that outcomes are honestly fairly equivalent between the two of them. So that's why I say it's kind of like surgeon's preference, surgeon's call. Whatever works best in your hands is probably going to be okay. Personally, I tend to shy away from the buccal added to these GRT cases unless we're dealing more with a potentially younger patient, somebody who's got like more of a form vitreous getting a GRT. Also, if the extent of the GRT is inferiorly, those can be pretty tricky. I'm more inclined to put a buccal and do the vitrectomy in those cases. Otherwise, if the vitrectomy is, as in this case, something that's superior, supratemporal, temporal even, I'm more inclined to want to just get away with just a vitrectomy alone. I find that I have less a risk for slippage at the end of the case. That's the thing we're always so worried about is, whether you're going from PFO to air and putting gas, or PFO to air, putting oil. Some people like to do PFO direct to oil. I'm sure we'll talk about all these things. You're ultimately worried about slippage of the retina posteriorly.
Yeah, no, all great points. These are very high risk eyes. Obviously, a lot of RPE that's exposed here. There are patients at very high risk for developing PVR, and that's probably the most likely reason in this case for the patient to fail whatever surgical intervention is undertaken. I like to put a band on, but I don't like the band to be too high. Yeah, I think it gives some support to the vitreous space, particularly at the horns. That's where I'm really the most concerned that the retina is going to redetach. But not having such a high band can mitigate that concern for retinal slippage. And in a phakic eye, I will almost always put a band on. Pseudophakic eyes, if in this particular case, if this patient were pseudophakic and it looks like the detachment doesn't, maybe extends right about to the horizontal meridian, maybe just a little bit inferior, I might consider putting just doing the vitrectomy and not putting a band on. But if it's extending more inferiorly, again, I'm just very, very concerned about PVR forming at that inferior horn, and so I'd probably be more apt to put a band on. But as you said, it's really surgeon's preference. Let's see what Dr. Silva does. All right, so Dr. Silva is showing us here that he is actually doing both a buccal and a vitrectomy. You can see this encircling band that's being placed And now with scleral depression, as you suggested, it's very important to really clean out as much of the vitreous as possible. Now, in patients who are phakic, do you make them pseudophakic so you can get a little bit more of an anterior shave, or just try to do as best you can with the lens intact?
I haven't had to do that. I think when you're working with trainees, there's always that possibility. One of the questions I get a lot of times from our fellows is when I'm doing a case in a phakic guy and I'm doing my uh, depression, my shaving under their depression, they'll ask, how far can you extend, to the other side with your cutter? And it's one of those things. It's you only know as much as you know how far you can push it in your own hands. Obviously, with trainees, we're always very cautious about how far over you can get, but once you've done this long enough, you get kind of an idea for as far as you're extending to the other side, cheating your instruments a little bit more posteriorly, not having them be anterior, so you run less of a risk of potentially having an iatrogenic injury to the lens. That's so obviously our concern. I've never had that happen again, but again, when you are dealing with trainees, that is a possibility that you may violate the lens capsule. If that happens, and your view potentially can start to go bad during a case. And look, if that happens, you got to take the lens. I mean, I think it's part of the consent process for these patients. Our goal is to get your retina reattached by any means necessary. And in some cases, if it requires getting your lens out of the way to get a more thorough vitrectomy, then that may be the case.
Yeah. Yeah, I also haven't really been in a situation where I've had to remove the lens. In terms of how far one can go on the other side, I usually tell fellows that they shouldn't go any further than roughly the equator on the contralateral side. And then when they're going inferiorly, I usually have them stop at around the 6 o'clock clock hour position. And superiorly, they can go around to the 12 o'clock clock hour position and extend maybe a little bit further nasally or temporally, depending on which eye we're operating on.
So
But
where again, another question I get asked because I use that term a lot is where's the equator? How do you define where
well, I
exactly
think
the equator
I
is?
think the vortex ampullae are a really good marker for that. So I'll usually just use that as as the gauge for where roughly the equator is located. How about you?
Yeah, that's my anatomical landmark. But all these eyes are shaped differently too, and so part of that has to do with where you see the curvature of the globe kind of changing. But generally speaking, the vortex veins are a good marker for that.
So let's look again at what Dr. Silva is doing here. So you can see the shave with scleral depression. And you can see here that he's trimming back that anterior stump of retina that's right at the ora serrata. You can see a really nice buccal contour there, but he's coming all the way across. So my guess is that this is a pseudophakic eye since he's coming across, completely across to the contralateral side. Now putting some perfluorocarbon liquid down, and with the PFL stabilizing the posterior pole, is doing some peripheral shaving here. It looks like he's even trimming back some of this rolled edge, and I like that. I like kind of freshening up the edge of the GRT, especially if there's a rolled edge. There's a risk that there might be a little bit of PVR that's already starting there. How about you? Do you like to kind of trim back or freshen up that edge?
I do. I mean, depending on the acuity, how recent this is, sometimes that edge can already be pretty rolled up. It starts to be a little bit firm. You're worried about like early PVR developing. I will advise to kind of like trim the edges in those cases. I really like the attention to focus on the horns here, like you said, really cleaning up the vitreous in that area. Obviously marking it for your subsequent laser as well. And this is the part when you're doing FAX where it can get tricky if you have a high buckle. Sometimes you just get this trapped fluid posteriorly, and you just can't drain it. Like you got a high buckle margin there, your retina is pretty much flat on it, then you're trying to get whatever residual fluid out. You can't, and then this is what happens when you start to deal with slippage. So I think in this case, did a very nice job. Didn't deal with that at all. The extent of the GRT is supported very nicely along the buckle, and it looks like he opted for using oil in this case. I mean, what's your feelings about tamponade choice for deep GRTs?
Yeah, I mean this looks like it goes a little bit more inferiorly. And so I like to go ahead and put oil in these eyes, but if it's largely in the superior, let's just say from the 4 o'clock to the 7 o'clock or 8 o'clock clock hour position, I might be comfortable with just putting a long-acting gas bubble in.
Yeah, I agree with that.
So a really nice anatomic outcome here. Obviously, oil is still in the eye, so we'll have to see how this patient does. But the point that you were making at the very beginning of the case of avoiding slippage is a really important one. You can see that Dr. Silva was spending some extra time draining right at the retinectomy edge, and that's probably the most important thing. Not, when you have PFL down, you've got that bubble of PFL that's flattened out the retina, then you've got fluid that's anterior to that. When you're doing your air fluid exchange, you've got an air bubble that's sitting on top of the PFL bubble, and then in the sort of the wedge between those two bubbles, you've got BSS, and you have to drain that BSS. Depending on how much residual vitreous there is, that vitreous may be hydrated, and so some of that fluid may come out. So you kind of have to spend a lot of time really drying, for many, many minutes, 5 minutes, 10 minutes even, some surgeons do, to make sure that every little bit of fluid has been removed before taking the PFL down posterior to the GRT edge. Um,
Yeah, the one of my mentors at Will's, Sunir Garg, he would really harp on these type of cases, and he would just make us sit there and wait. And this is the one part of the case you are absolutely should not be in a rush. You should be intentionally slow and methodical, go to the edge of the retinectomy, drain, sit there and wait. Like to kind of like tilt the eye in the direction of your um, retinectomy edge or GRT in this case, and intentionally just let fluid pool there and gravitate there and repeatedly come down every minute or two and get as every last bit of fluid that you can out. It makes a big difference. So you don't be surprised if you spend at least several minutes, 3 to 5 minutes here doing this, making sure it's completely dry before you then proceed to remove the PFO.
Yep. So let's say you've done all of that, right? And despite all of those efforts, there still is some slippage. What do you do then?
I think again, knock on wood, I haven't had that happen. In these cases, should it happen, I think you have to decide how much slippage are you getting. Is it something that's extending pretty far posterior where you need to intervene, or if it's hanging out in the periphery, you actually might be okay. Assuming it's something a little bit more expansive, you may need to consider going back to fluid, putting PFO back in, and then this is where some colleagues are fans of doing a direct PFO to silicone oil exchange, if that's something that you were planning to use from an oil tamponade perspective. Have you
Yep.
done that technique before?
I have, and it works pretty well actually. So I've done it where I have actually had my assistant hold the silicone oil injection cannula in one trocar, and I've got my light pipe and my soft tip in the other, and it's just a passive aspiration of the PFL as the oil is going in. You can also do. There's a setting on the Constellation that will allow you to do both an active injection and active extraction. You can certainly use that mode as well if you'd like. When you do get slippage, another option could also be just to use a soft tip or even like a brush type soft tip to kind of just smooth out the slipped area. And there's presumably a little bit of fluid, a little bit of BSS that's slipped underneath the retina. And as long as there's not a lot of it, you may be able to just brush that retina back into the proper position and then just position the patient face down or in depending on the configuration of the GRT, whatever position is going to help to sort of flatten out the retina. I usually would just keep patients face down for the first 24 hours and then I'll modify their positioning depending on where the GRT is.
It's a great discussion. It's kind of a takeoff point to this, though. It's just in general, if you're dealing with, say, a bolus detachment and you have a little bit of trapped fluid post-op, how do you position your patients? It's kind of what you were just getting at the heart of. A lot of people would say they just go immediately face down in the post-op recovery area. I think I'm more in the camp of just dependent side down positioning. So a temporal side down positioning, it's like a superior temporal RD, letting that fluid kind of gravitate out. It'll be gone fairly quickly. Can smooth out that retina nicely, and you don't end up with what you fear would be like a retinal fold or something extending posteriorly postoperatively. So there's a really nice article. I mean, I remember I learned that technique from I think Paul Hond and Cindy Toth had kind of written about it. This kind of temporal side down positioning, and at least that's what we do in our PACU. Partly because you get to learn the staff well wherever you work. You may write down something, and you may assume that happens, and sometimes you go out in the recovery area, and then maybe new staff, new team, new nurses there, and your patient's not even face down; they're just kind of upright, sitting there eating. So I found that sometimes the easiest way to do this is I put that patient on that dependent side down position and make them that way before they leave the operating room. And I tell them they do not move from this position for at least the next 30 minutes. And then they can kind of get up and be upright if they need to.
No, that's a great point. I have been in situations where I've gone to the PACU and that's been the case. And I always also always communicate those plans to the family who's going to be with the patient. You know, they're groggy, they're maybe not completely with it when you're in the PACU with them after they've come out of surgery. And so making sure that whoever is going to be driving them home and kind of staying with them, that they can help the patient to make sure that they're in the proper position.
Awesome.
Excellent. Thanks so much, Ehsan. Great
Well,
discussion.
thank you for our colleague for sharing this wonderful case. Congratulations on a great outcome.
Absolutely. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.